so much. So, I think one thing is, the liquid biopsies in terms of what they're able to detect in blood will only get good enough. I think when we say liquid biopsies, we didn't talk about other bodily fluids where you can still use it for detection of whatever DNA. So there's, for bladder cancer, urinary DNA, for peritoneal, we did some work with our colleagues at University of Iowa where we did peritoneal washings for circulating tumor DNA for the high-risk patients. So that could be ways to overcome, barriers to whatever can be detected in blood. So that might be one way forward, would be to not just rely on cytology for malignant cells, but consider peritoneal tumor DNA or ptDNA as, or whatever. For example, for cholangiocarcinoma, bile is still a very close to the proximity of the site of metastases. That might be one way of overcoming whatever blood cannot detect.
Great. Also, I've heard that people are also checking CSF, right?
Yeah.
For single solitary site disease, right?
Yeah, and it's not uncommon with these patients with colorectal cancer, young onset, that they're living long enough that now we have patients with leptomeningeal and brain metastases that are a challenge to manage. But a lot of these are getting intrathecal chemo and they're getting their CSF type every so often. So that could be used for. There are actually several companies with approved assays that can be used to detect CSF or ctDNA.
Thanks. First question, I believe Dr. Gruber.
Dr. Yu, congratulations on outstanding work. When we do a surgical resection for a patient with colorectal cancer, we're not just getting one whole slide image. Pathologists are reviewing dozens of slides. When you're training your foundation model, are you using just one slide or are you using all those slides with multi-instance learning? And what are the issues associated with the heterogeneity, intratumoral heterogeneity, that informs the way in which you're training your models?
Yeah, that's a very good question. In training our foundation models, essentially we take all available slides from our study cases. So for example, for surgical resection cases, we might occasionally get like 10 or even more slides. In our process, we just digitize them all and train from all those slides. And the approach for aggregating the prediction result is a attention-based method, meaning that our model would assign different attention weights to the different regions and different slides. And at the end of the day, in order to get a patient-level prediction, we aggregate the prediction for individual patch and individual site according to the amount of weight and amount of importance that our machine generated.
And just as we think about the way in which to take advantage of existing data, like you used the nurses' health study, the health professional study, are you able to get all the original H&E slides? Or are you getting one representative slide? And how confident are you that that reflects the full complexity of the case that a pathologist is looking at?
Yeah, for cohort studies, we generally have more limited view because of the constraint of the, for example, study funding. So for nurses' health study in particular, we only use the tumor microarray, meaning that we only have one selected tissue patch, and we are forcing our model to make a prediction out of it. And I agree, when we are handling cases with high tumor heterogeneity, this may be a potential issue. For example, the prediction from that particular patch may be, for example, MSI high, but as long as that particular patch is not very representative of the entire biology of the tumor, we might be mistaken.
Thanks.
So I have questions for each of you. Just continuing with Dr. Yu, because you're talking about Dr. Gruber brought up the nurses' health study. When you were training the model and looking at the system and trying to teach it, the nurses' health study and health professional study, these have been going on for decades, right? So survival now is very different than survival 20 or 30 years ago. I mean, I even showed that for pancreatic cancer yesterday. How do you correct for that survival today?
Yeah, totally. In our case, we restrict our analysis into the nursing health study, I believe, is the recent 10 years. So we only take the more recent cases where their treatments are more up-to-date and more standard. And after that, we ask our model to predict whether they can identify the high mortality versus the low mortality risk patients from there.
from more recent patient
Exactly.
cohort. Okay, thank you, that makes sense. Dr. Kasai, so you talked about using circulating tumor DNA and a liquid biopsy to, you talked about a study where you actually treated patients before, presumably radiologically they had recurrence of their disease. And I'm happy to hear from any of the oncologists in the audience too. I don't know that our oncologist would treat somebody just based on a liquid biopsy. Are you doing that at your center? What would you say to oncologists elsewhere?
So the field is very rapidly moving. I guess the best thing is, of course, it's easier when you're enrolling in a clinical trial. Now again goes back to what assay are you using. So, while there could be, let's say, false positive on a random plasma-only assay that may or may not know the entire context, but for a tumor-informed assay, for example, which was used in this study for the KRAS vaccine, I think it would be hard to imagine that if you're, for example, have a bespoke panel, you know that, for example, this patient with pancreas cancer has KRAS G12D mutation. You're using, in the study actually they used a both plasma-only assay as well as a tumor-informed together from a correlative standpoint. You're detecting the same KRAS G12D, the same TP53 aberration for a patient with pancreas cancer that you showed the survival for. That's cancer that's proven otherwise. Outside of trials, the cases where we're comfortable in treating or at least bringing up the question of starting maintenance therapy is your stage 4 oligometastatic colorectal cancer. Half of them are not cured with curative intent therapy. So in those patients, if you're monitoring the assay for surveillance, it's not uncommon to consider maintenance therapy in those situations. We also published an editorial on this topic. If you switch the modality from cross-sectional imaging to functional imaging, so for in the appropriate patient, a CT reflexing to an MRI or a PET scan or a diagnostic laparoscopy in your T4B patient, I would say more than 2/3 of the time you will find the actual radiologic or pathologic recurrence. But FDA is recognizing this as an endpoint, MRD positivity as an integral endpoint to enroll in trials in the appropriate context, and also MRD clearance as a quick endpoint to long-term efficacy in DFS and OS. So again, not meant to replace the field, but the fact that there are trials that are enrolling, and also in the stage 4 oligometastatic, I think as the assays are getting better, less chance of a false positive, it's informed decision making. It's happening.
No, I think it's very exciting. Thank you. Dr. Keole, thank you for making radiation therapy so much more understandable. I can't even begin to tell you how much you took my knowledge from here to here today, so thank you for that. The last case that you presented that was the large liver tumor, looking at the liver at the onset of the cancer, you could see why that wasn't a resectable tumor, right? The vast majority of the tumor, of the liver was cancer. But at the end of the treatment, the other lobe, the left lobe, had hypertrophy. Is that a patient that we would then send to surgery for resection of the primary tumor, or what ended up happening with that patient?
That's a good question. I don't know. But the pictures are cool. But the pictures are good.
Absolutely, absolutely.
So I have to ask a question to Dr. Keole, my friend.
Yeah, they do.
That's off. Okay.
There it is. All right.
So, Samir, what do you think about, you mentioned Theranostics. Obviously, it's a exciting area that's expanding into, is ever growing. What's the role of the radiation oncologist, and also in terms of potential combination with external beam? Is that a potential? Because right now, of course, that's not being done. But is there a role for local therapy in combination with Theranostics, and the role for radiation oncology in that area?
Great question. And the right answer is I don't know. But I tell you what I think is the situation after I've dived deep into this in the last year. Unfortunately, we're ending up, for those of you who don't know me, sometimes I'm too candid and too honest with my thoughts. We've somehow been catapulting down this turf war, down the road of this turf war with kind of radoncs on one side and then medoncs partnered with nuclear medicine on the other. And I think that's wrong, and I don't think it's the best thing for the patients. I think what's happening in hospital settings is that medical oncologists are working with nuclear medicine docs, and the radoncs are largely on the sideline, have no idea what's going on with all of this. And then if you go to community settings, nuclear medicine, radiation oncologists are the ones delivering this. And so you have two widely disparate areas of care. So I think that the examples are, these tumors are, what we're learning, are pretty heterogeneous. Like even like, for instance, prostate cancer, you might have different cell types. If you have 10 lesions, I was talking to an expert in this area, like 5 might respond to lutetium. But then the other 5 don't, and probably those need to get stereotactic body radiotherapy, the SBRT, to those 5 lesions. And so I think it's incumbent on all of us, and that same example can apply to any disease site. So I think it's incumbent on all of us to work together to make sure that the patients get the right treatment that they need, because we're not hammers and no patient should be a nail. And so to that extent, we're trying to work, I've been meeting regularly with SNMMI leadership, and so we'll have a joint session at their meeting in New Orleans, and then we'll have a joint session with them at our meeting in Astro. I think the second question is interesting, how do we combine it? So I think there are companies emerging, and we're trying to work with them on radiopharmaceutical dosimetry. And so seeing, right now we just give a set amount of dose. We're gonna give X amount of millicuries, usually weight-based dosing, and we just give it. And I think what we're going to see is, hopefully in 5 years, if not sooner, is personalized dosimetry, similar to what we do post-brachytherapy or prior to external beam, so we can actually see what was the uptake, and then based on that, it might be actually selective dosing with SBRT. So that's what I think is going to happen, but believe me, I've gotten a lot of things wrong in my life. But that's what I think, that's the answer I'd give you today.
Just a follow-up question on that. Liver-directed therapy, as we know right now, there's, like you spoke and we had this session yesterday, it's an evolving paradigm right now, right? And there's no clear clinical pathways yet. Moving forward, where do you see ctDNA kind of incorporating with radiation oncology there, particularly for SBRT?
That is another very, very good question. And so for this, I've talked to actually folks a lot smarter than me, and Stephen would be one of them. I've talked a lot with folks like Max Dean and Scott Bratman and Adil Chowdhury, who's at Mayo. What I really didn't appreciate, especially after talking to Adil, is this concept of MRD. It's been there for a while, but the technology to detect MRD really was not that great. You probably are very familiar with this, so the technology that was there in 2016, 2017, when the Stanford group did a lot of one of the sine qua non moments, at least for me at Astro, was the Dean Lab from Stanford had a presentation at the 2017 Astro meeting where circulating tumor DNA was clearance was predictive of long-term outcome. At least for me, that was like one of those, holy smokes, this thing is coming, just a question of when. But then as I've gotten into this space, that technology just isn't there, but now the sensitivities are getting so good. And so I think that's where we're going, because right now the technology is not there with the theory. So I think as the technology catches up, I think we're going to use it. That's what I think. But I think we're technology dependent here. That's my opinion, but there's a lot of smarter people.
And building on some of the work from Adil, who's at Mayo right now, one of the works that presented at Astro last year was, for example, we always talk about the quote-unquote oligometastatic patients who have 1, 2, or few metastases. Do we go after them? And it was intriguing work from his lab where it showed that folks who had ctDNA negativity or MRD negativity before the whatever local plan, they were the ones who drive more benefit from it. So again, that's just one idea or suggestion of how to pick local regional therapy for somebody with metastatic disease. But I think, as was mentioned, as the technology improves, that it's going to be which clinical context and which patients we use the assay for.
I just want to mention, there's the randomized. Hello.
Yeah, it's like the randomized curve trial, oligoprogressive, right? They actually looked at lung and breast. So it's always actually the question is actually, are you treating the tip of the iceberg?
Right.
And you can show that in breast cancer. It's just you see the ctDNA change with local consolidation. It just doesn't fluctuate. But for lung cancer, for not all patients, but a good number of patients, it actually drops.
Right.
So suggesting you may be treating not the tip of the iceberg, but that's all what you see is what you get. and maybe not for all disease type or certain sites. That's what you see. And I think MRD and ctDNA is going to really help with that. Yeah.
And just two quick comments building on that. There's also now ability of the assays to predict where the ctDNA is coming from. So very soon you will see the assay, for example, saying that you're detecting this much ctDNA, 70% of this is coming from the liver, 10% is coming from the lungs or the bone, because the same tumor DNA in different environments acquires different epigenomic signals. So that might also be helpful in guiding therapy, or where is this MRD coming from. And then one other thing, the folks at MGA and Farber are leading, there's now an MRD consortium that's going to allow for industry and lab to kind of have an ongoing clinical trial platform, because it gives you very quick endpoints, and it gives you the highest, anybody who's MRD positive, you can see from all the curves, they recur very quickly. So from a clinical trial design standpoint, you can acquire the highest risk patients with the lowest amount of cancer, and also a very quick endpoint to accelerate, clinical trial development.
So essentially, can the methylation signature give you where the site of origin may be? Next question.
Dr. Kasi, for a patient with colon cancer, metastatic, no evidence of disease, how do you use exactly MRD for maintenance therapies? So would you keep just doing maintenance as long as the MRD positive and there's no endpoint? And what kind of maintenance do you use? Just light form like 5-FU, just remove more like ionic ads, dexamethasone, stuff?
I guess, I was spoiled because we had the opportunity of enrolling them in the appropriate trials. So for the HER2 positive patients, we had a HER2 arm of a study that we collaborated with NGH. We had a BRAF arm, we had an NSI arm. The folks in UK, they published the so-called Pegasus study, where if they had received FOLFOX-based therapy by pivoting to FOLFIRI, you were able to clear another 40% of the patients. So I think there is more precedence, but I wouldn't necessarily start therapy on a stage 2-3, because like I said, you'd rather enroll them in a clinical trial. I don't think we're there yet to just switch to a different chemo. I'm not sure if that will help them. But I think by just even alternating imaging or increased cadence of imaging for those patients, or MRI, PET scan, and I think the timeline of 9 to 12 months is in a hindsight and bank samples where the patient and the provider didn't know that you're MRD positive. Dr. Fakih presented some of the work yesterday. When the patient and provider knows that the patient is MRD positive, it's pretty much your next scan. The time to recurrence is not the 9 to 12 months, it's actually probably in the order of 4 to 5 months.
Thank you.
Dr. Kaiser.
I have a question for Dr. Keole. First, just to do a little bit more tutoring for my understanding of radiotherapy. One is the term of gamma knife. Where does that actually fit in? Because there was a lot of hype. Is that now just IMRT, or is that SBRT? And the second question is a little bit more like, what does the future bring in terms of maybe doing some liquid radiation therapy, like linked to antibodies or something like that?
Oh, great questions. So gamma knife is, it's a commercial term. It's from Lars Lesko, a neurosurgeon who actually invented it in Sweden. The gamma refers to cobalt. So cobalt emits gamma radiation. It's exactly 1-for-1 in terms of everything it does from a linear accelerator. A linear accelerator is not radioactive. A linear accelerator is called a linear accelerator because literally you accelerate electrons from a negative to a positive source. So it shoots down a vacuum tube. All this originated actually from vacuum companies, by the way. That's where Linux started. Not the sexiest, but it hits a high density target, and then out comes something called Bremsstrahlung radiation, but it's biologically identical to cobalt radiation, which is our historic unit of measurement. It would be like in currency, it's the dollar. Everything's indexed to a cobalt. So gamma is cobalt, and so a gamma knife used to have 201 cobalt sources. Now it has 192, which is, I guess, irrelevant. But so, for example, a linear accelerator in states where there's state regulation, because they don't all have them, would fall under the auspices of the state. A gamma knife would fall under the auspices of the Nuclear Regulatory Committee, the NRC, which obviously has a whole slew of headaches, which is why there's vendors coming up trying to replace the gamma knife. But the gamma knife focuses those 192, you're in a helmet, You have 192 cobalt sources. They come through little circular apertures, and they end up in the same place every single time. So you move the patient relative to what we call that isocenter. So that's a fixed unit, but it's great. For a really eloquent tumor, you can what we call packed spheres. You move the patient, and it's a remarkable distribution. But it's essentially, if I was at a neuroscience meeting, I would get probably beat up outside for saying this. For 90% of intracranial targets, maybe 100, there's probably not a big difference between a linear accelerator radiosurgery plan and a gamma knife plan. That being said, if I said this at a gamma knife meeting, the pitchforks would come out and I'd be jumping through that window because there are loyalists. I think the liquid RT is coming. I think as we identify antigens and come up with ways to target them and take payloads, it doesn't do great with a big bulk of disease. Depending if it's an alpha or beta emitter, it can't travel that far. So it's really good for low burdens of disease in a lot of areas. It's probably, I don't see it right now being great where you have a big nidus of tumor. So I think they're complementary. Where I do see the liquid radiation, like the radiopharmaceuticals, where I see it is oligometastatic and polymetastatic disease, which we haven't talked about. That's actually one of the sessions at our annual meeting. I agree. There might be people with 1 or 2 lesions, we can't cure them. There might be people with 8 to 10 lesions and we can put them in long-term remission, and we need to learn more on that. Sorry to talk so long.
Rahul Panola, Mayo Clinic, fantastic session. I wanted to sort of, we talked a lot about MRD. Dr. Kun-Hsing, one of the challenges you touched upon cholangiocarcinoma. One of the things that we see as gastroenterologists a lot is what we call indeterminate strictures, like biliary strictures, pancreatic strictures. So obviously there's very little data or no data in liquid, ctDNA, cell-free DNA in this space, but I've always been intrigued about the diagnostic aspect of it. So as a field, as we navigate this, I guess my question is more, is anyone doing it right now as sort of, 3-year CP is negative, get a liquid biopsy? We've done it once or twice, but how do we, create or design studies to apply that in this space? And how do we go about that?
It's very interesting. Cholangiocarcinoma is always like the ignored poster child, but if you look at any study, you look at the GRAIL study, the Gallery assay, the top performing is not your colorectal cancer patient, actually it's your cholangiocarcinoma patient. If you look at any study of survivors of fusions, patients doing the best is your fusion from a cholangio patient. So from a blood testing standpoint too, these cholangiocarcinoma patients, even the localized ones, are shedding enough whatever DNA methylobin signal where you can use some of these assays. One anecdote of a stage 1 cholangiocarcinoma patient was a patient who actually did one of those commercially available assays without a biopsy, and that biopsy said 60% chance colorectal cancer, 50% chance gallbladder cancer was what prompted him to get surgery, and it was lo and behold cholangio. To your point about who else is doing work on it, University of Pittsburgh has developed an assay, and it's getting more approval across other states, and they're using the bile for DNA because that's where you're at, and often it's not uncommon. Several patients, several biopsies, several ERCPs. It's all very concerning, and you don't have a diagnosis. Additionally, the subset of patients who have PSC, identifying the Mayo Clinic patient transplant protocol. Some of the patients got transplant. We don't even know if they had cancer. I think that's where not just the blood alone, but pairing the blood with ERCP with bile. So the University of Pittsburgh's pathology group has an assay that's already available, but I think it has to be more commercial mainstream. There's a good opportunity for some of the larger companies to go beyond blood.
And I was just going to comment on exactly that. There's studies now looking at, though blood is the most easily accessible, that's why it's kind of picked up so much with MRD and ctDNA. You're actually better off looking at where is the tumor shedding most proximally. So is it urine, if you're looking at a urinary tract lesion, a bladder cancer, is it bile or pancreatic fluid? The same assay for DNA mutations can be run in any of those. You know, stool is obviously already garnered a lot for colorectal cancer. So blood is just the most easily accessible, but there's a lot of data and looking at urinary samples, especially for bladder, prostate, because you're going to secrete tumor, the closest kind of vehicle to it.
So from a practical perspective, if we had a patient today, is something available?
For the University of Pittsburgh assay, it's a send out. When I was at Cornell, we were frequently sending these exact same patients at the time of their PSCP. The bile collection is something that goes out to them. New York has an additional layer of approval, but that's available for other states.
Dr. Yu, just a quick question. So in your foundation model, I mean, it's incredible you trained all this on the H&E slide, right? But with all the spatial technologies out there and spatial genomics, and this is done much cheaper now, is there still a way to update your model using those additional information? And is it open source now, this data, that where others can upload and also further improve on that model?
Yeah, totally. Our model is fully open source, so it's published along with our paper last fall, and anyone can download it from GitHub and further benchmark it. I know that there are currently a few community-led studies trying to benchmark this particular foundation model chip that we developed with many other approaches that people are developing right now. And related to the first question is about, what was the first question?
Just upload spatial data, spatial
Oh, yes, that's right. So currently we are also working on integrating H&E with spatial proteomics data, for example, those from multiplex. And we are seeing exciting results because those multiplex imaging give us single cell level molecular profiling results. So it enhances greatly our efficiency in learning the correlation between H&E pathology and the spatial proteomics and spatial transforming data.
Dr. you had pointed out about, particularly about cancer of unknown primary origin, which we struggle with both in the clinic and on tumor boards per se. Where do you see sort of that field moving forward? Do you see methylation signatures or proteomics? Where do you see where that's moving forward to help us make the diagnosis there for those patients?
Yeah, totally. We know cancer of unknown origin remains a great diagnostic challenge to ask many people in this room. And our approach is to develop a multi-modality model that not only incorporate H&E pathology, but also some molecular studies, including methylation and other results from right out of the sequencers, in order to jointly predict the most likely sources of the tumor. And not only we provide the top hits, we also provide a confidence score, such that clinicians can better find their clinical correlations with patient manifestation and their clinical history.
I just want to quickly add, I think there are at least 3 commercial platforms that are leveraging AI into their thousands of patients that they've sequenced over the years with DNA and RNA. Tempus has one, Caris has one. The cancer type ID that's Medicare approved as well. Again, not to replace the pathologist, but complementary to using AI. That's one innovative area where, with fair bit of accuracy, we see a lot of them in our CUP clinic at Mayo. Actually, there's a whole clinic that's manned by GI Oncology. That's the CUP clinic, and by some of these assays are adding value to the clinical decision.